Kindly confirm all delegates join, experts join.
Yes, Thackeray sir and Gaurav Bhaiti sir remain. They are joining. They are having an while joining problem. हॅलो बरोबर चालेल सर पाठवतो मी तुम्हाला
Ravi, who all have joined?
Parvesh sir has been joined. Then after
I request all delegates to open the video. Is a expert summit, sir. No, only discussions happens on. I request every delegates to open the video.
Oh, yeah. Pagare sir, good evening.
गुड इव्हनिंग.
कशात सर?
ठीक आहे एकदम कम्फर्टेबल.
या मुंबईला का?
नाही औरंगाबादला जा.
औरंगाबाद आले का? ओके ओके ओके. Sir, good evening, sir. Abhi sir, good evening. Vishal sir, Abhi sir, good evening.
सर गुड इव्हनिंग. म्यूट होता अगोदर. गुड इव्हनिंग.
Okay, good evening.
Sir, without not wasting much time, can we start? I will brief introduction all the delegates and then we'll start with the expert summit.
Yeah.
Yes, sir.
Please request all delegates to, all physicians, our colleagues to start with video, because this is like more of discussion, so that.
Yeah. I welcome all the experts here. The moderator, Dr. Mukund Bajaj sir. Mukund Bajaj sir is a MD General Medicine, DM Cardiology. Currently at present Director and Chief Interventional Cardiology at Asian City Care Super Specialty Hospital, Aurangabad since 7 years. And the visiting cardiologist at Alpine Hospitals, Aurangabad. So having a huge experience of cardiology in Aurangabad, and expert panelist today on topics MRA in heart failure, jump on the bandwagon. Dr. Manav Pagare sir, Dr. Mahesh Bansode sir from the Sri Sai Hospital and ICU, Silot, Dr. Parvesh Qureshi sir, consulting physician, Qureshi Hospital, Aurangabad, Dr. Mohsin Abidi sir, Sara Hospital, Aurangabad, Dr. Gaurav Bhaiti sir from the AIMS Hospital, Aurangabad, Dr. Vishal Thackeray sir, Sai Hospital and Critical Center, Aurangabad, Dr. Abhay Pohekar sir, consulting physician, Nilkant Hospital, Aurangabad, and Ghanshyam Chandak sir from the Navjot Hospital, Aurangabad. I welcome all the delegates here for the today's discussion on the MRAs in heart failure. I welcome sir Bajaj sir, hand over session to you for today's expert summit on strengthening hearts.
Good evening, everybody. My dear seniors and my dear colleagues. It's been honor to share this platform with you. It has been long that we have not met, and I'm really glad that we are here together on this platform. Basically, today I will be, in fact, I will be speaking and we'll be discussing on role of middle corticoid receptor antagonist in heart failure. The agenda would be to re-emphasize the role of MRAs in heart failure, bring out their utility, what they give us in management of heart failure, and then we will be starting with our discussion slides. So initially I will be going through just introduction on heart failure and pharmacological aspects of middle corticoid receptor antagonist for next 10-15 minutes. Then probably I'll set a ball rolling and we'll have a discussion. So I'll be sharing my PowerPoint presentation. I hope that it will be so are my slides visible?
Yeah.
Yes. Yeah.
Yes.
So basically, middle corticoid receptor antagonist boon in heart failure management. It's a disclaimer slide that the contents of the slides are designed for gaining insights and for consultation purpose only. It's not for any promotional purpose. Use of brand names, if any, is purely out of habit and convenience and not for promotional purpose. And meeting is being recorded, but it won't be used for promotional purpose as well. So objectives of today's program would be to gain insights on middle corticoid receptor antagonist, its placement and utilization in heart failure management. Hyperkalemia after the usage of MRAs, is it really concerned in the physician's practice? And to create awareness among physicians on middle corticoid receptor antagonists. So coming to heart failure per se, heart failure is rampant and it is a global phenomenon affecting almost 2.5 crore people worldwide. It is estimated that almost 1 to 2% of adult population in developed countries is suffering from heart failure, and prevalence of heart failure increases with age, rising to affecting almost more than 10% of people after the age of 70 years of age. As far as India is concerned, it is estimated that almost 1% of total population is suffering from heart failure. Annually, we are adding almost 0.5 to 1.5 million new cases per year, and it carries with it a high mortality. The mortality is to the tune of almost 1 lakh to 1.5 lakh individuals per year. So as far as management of heart failure are concerned, there are many therapies which are being used to improve mortality and morbidity in management of heart failure. But having said this, we have to accept that uses of middle corticoid receptor antagonist, in spite of being proven therapy in improving mortality in patients with heart failure, they are not used as much as they should be, and it is definitely can be easily said that MRA are the neglected pillar in management of heart failure. So as far as management of heart failure is concerned, as far as medical therapy for heart failure patients with reduced ejection fraction is concerned, we have 4 pillars which are known to improve survival, or which are known to improve mortality, have a mortality benefit in patients with heart failure. These are first class of drugs are of ACE inhibitors, ARBs or ARNI, which we are all well aware, and I am very sure almost each and everybody of us are using the same class of drug. Second class include beta blocker. Third class includes middle corticoid receptor antagonists like spironolactone or eplerenone, and new class of drugs which is introduced just a few months back and has been shown to improve mortality are uses of SGLT2 inhibitors like empagliflozin or dapagliflozin in patients with heart failure with reduced ejection fraction. So this quadruple therapy, that is 4 class of drugs, are the one which are shown to improve survival in patients with heart failure. This is regarding medical therapy. So this is just a chart which shows that the drugs which are known to reduce mortality for all patients with heart failure are ACE inhibitors or ARNI, beta blockers, MRAs, and SGLT2 inhibitors. Other drugs which are known to help patients with heart failure doesn't improve mortality. Other devices which doesn't come in medical therapy includes CRT, ICDs, surgical repair of aortic wall or tower, or use of anticoagulations, but these are not essentially medical therapies. So coming to the role of mineralocorticoid receptor antagonist, we have to first understand what is heart failure cascade and what is the role of aldosterone in which helps us antagonizing it and helps us reduce mortality. When we see any patient with systolic heart failure or heart failure with reduced ejection fraction, that is ejection fraction of less than 40%, then they have reduced cardiac output. Reduced cardiac output in turn leads to activation of RAS system, which leads to increase in aldosterone levels. Increase in aldosterone levels lead to increased sodium and water retentions and all types of congestive symptoms. At microbiological levels, elevated aldosterone levels lead to cardiac hypertrophy, increase in myocardial fibrosis, impairment in contractile function of heart, and progressive chamber dilatation. This all leads to increased propensity for QT dispersion, increased chances of ventricular arrhythmias, and sudden cardiac death. So much are the harmful effect of aldosterone. So this goes without saying that antagonizing aldosterone will improve for sure mortality in patients with heart failure. So again, the chart, flow chart, which shows that management of heart failure patients, ACE inhibitors or ARNI, beta blockers, MRA, and SGLT2 inhibitors are the class 1 indications which are known to improve mortality benefit in patients with heart failure. So as we all know that, just going through the slides, heart failure can be classified in patients with heart failure can be classified in patients with heart failure with preserved ejection fraction, patients with mildly deranged ejection fraction, that is ejection fraction between 40 and 50%, and patients with ejection fraction of less than 40% are classified as patients with reduced ejection fractions. The point of me showing that MRAs are the only class of drugs which are shown to have mortality benefit in patients with any class of the drug, any class of heart failure, that is heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, or heart failure with preserved ejection fraction. Having said that, usage of beta blockers, usage of ACE inhibitors are of doubtful value in patients with preserved ejection fraction. These are the set of clinical trials emphasizing use of various class of drugs and their mortality benefit. The red color clinical trials, that is RALS trial in 1999, EPHASIS trial in 2003, and EMPhaSIS heart failure trial in 2011, has re-emphasized the usage of MRA and their mortality benefit. My aim of showing this slide is it is not a new thing that has shown to improve mortality after using MRAs in heart failure. The usage of heart failure drugs, especially MRAs, and their mortality benefit has been emphasized with these landmark clinical trials way back, almost 2 decades back. Still, we all are not using MRAs as much as they should be. So these are names of 3 landmark clinical trials: RALS, EPHASIS, and EMPhaSIS. The first trial used spironolactone. The next 2 trials had used eplerenone in it. RALS had patients with heart failure with more severe symptoms, that is class 3, class 4. Etiology of heart failure was ischemic and non-ischemic, and primary endpoint in RAS trial was seen in only 38.1% versus 50%. So definitely usage of spironolactone had massive mortality benefit as compared to placebo drug. Same with usage of eplerenone in patients with post-MI, that is when it was used within 2 weeks of post-MI patients with mild to moderate to severe heart failure symptoms, and eplerenone when it was used in mild heart failure patients either of ischemic etiology and non-ischemic etiology. In both the trials, use of eplerenone was shown to definite improvement in primary endpoint. So this was regarding heart failure and emphasizing the use of mineralocorticoid receptor antagonist. Now we will be going to the slides to have some discussion within ourselves. So I will be inviting our panelists one by one for discussing each and every topic. If at all somebody has to share at some point, he can always have a say in it. So first point of discussion would be, what are the diagnostic and prognostic tools used by you in a clinical practice for management of heart failure? So I request Dr. Baheti to have a word on this. Dr. Gaurav?
Sir, you are on mute. Gaurav, sir.
Yeah, good evening, sir. Am I audible?
Yeah, you are.
Yeah.
As far as diagnosis of heart failure is concerned, there are different ways or different components which we consider while diagnosing heart failure, along with clinical presentation of the patient, electrocardiogram, 2D echo, different blood investigations like BNP and anti-proBNP, chest X-ray also play important role. Clinical presentation of the patient may present with dyspnea, PND, orthopnea, pedal edema, abdominal discomfort or right-sided abdominal pain, which probably because of congestive hepatomegaly, confusion, dizziness, maybe with syncope. On signs, he may have tachycardia, a low saturation, tachypnea, and so on. We have Framingham's criteria for diagnosis of heart failure depending upon predominantly depending upon the symptoms. It include two major criteria and one it include major criteria and minor criteria for diagnosis of heart failure. Depending upon the clinical symptoms, clinical presentation, we should at least we should have two major criteria or one major and minor criteria. Major criteria include PND, orthopnea, raised GVP, acute pulmonary edema, cardiomegaly, crackles, S3 LUP, or weight loss by more than 4.5 kgs in response to treatment for CCF. While minor criteria include exertional dyspnea, ankle edema, hepatomegaly, pleural effusion, tachycardia, heart rate more than 120 per minute, or weight loss of more than 4.5 kgs with other measure than treatment of CCF. As far as ECG is concerned, patient might have a low voltage ECG, cardiac arrhythmias, or acute STT changes on ECG. Chest X-ray usually shows cardiomegaly or pulmonary edema. Echocardiogram is, I'll say, a vital and important test for diagnosis of heart failure, as well as it gives idea about the cause of heart failure. Various structure like structural component or acute symptoms, acute signs can be seen on 2D cardiography, as well as heart, as we say, the classification of heart failure, like heart failure with preserved ejection fraction or reduced ejection fraction can be also seen on 2D echography. Blood investigation, there are various blood investigation which are used for actually to find out cause of heart failure, but BNP and proBNP have its own importance. BNP and pro-BNP are actually used, I'll say, for exclusion of heart failure rather than to diagnose heart failure. To diagnose heart failure, along with raised BNP values, we should always see the other factors, including clinical presentation and other investigations. BNP and proBNP both have almost same diagnostic and prognostic values. BNP, we say cutoff values of BNP, like as far as BNP is concerned, in acute heart failure, BNP values less than 100 almost exclude heart failure, or the values more than 500 are almost sure that it's heart failure only. While proBNP is concerned, the values are less than 300 milligram, 300 picogram per ml exclude heart failure. The values more than 1800 picogram confirms heart failure. The same values are different in chronic heart failure. As far as chronic heart failure is concerned, the values less than 37 exclude heart failure, while more than 37 goes in favor of heart failure if other clinical signs or symptoms are in favor of heart failure. What about gray zone? If there is gray zone, we already discussed that if BNP is less than 100, then heart failure is excluded in acute settings. If it is more than 500, then heart failure is sure in acute settings. But if it is between 100 and 500, then the diagnosis is totally dependent upon other symptoms, and especially on 2D echo. 2D, the imaging will play vital role in such situations. As I already said, usually BNP and proBNP's values are to be checked to exclude heart failure rather than to confirm heart failure, because there are various causes of pseudo increase in BNP values, like sepsis, acute kidney injuries, other structural heart disease, pericarditis, and so on. I feel it should be preferred to exclude the diagnosis, or to differentiate the cause of dyspnea or other symptoms, to differentiate between the respiratory and cardiogenic causes of the symptoms. As far as prognosis is concerned, the increase as the values of BNP and proBNP increases, the prognosis of the patient become worse and worse. Here, both the two things are important. Duration of raised BNP as well as in acute phase increase in BNP is also important. If in acute phase BNP is very high, then prognosis is bad. And if the patient persistently have high BNP for a long time, then also it is one of the bad prognostic factor. Along with BNP values, other comorbidities, age of patient, structural heart disease, underlying other causes, all play important role in prognosis of the patient. That's all from my side, sir.
Yeah, thanks, Gaurav. I think Gaurav had said it all. Just to add, there are few things which are known to increase BNP levels. With the increasing uses of ERNI, they are known to raise BNP levels. So if at all you are using ERNI, and then you are going to evaluate the patient on BNP, you should be cautious. It is as good as using SGLT2 inhibitors, having controlled sugars and getting urinary sugars, because they causes sugar excretion in urine. So that same way, ERNI are known to increase BNP levels, and so we should be cautious in evaluating patients with BNP levels if at all patient is on ERNI. That is one point which I wanted to add. Second thing is other lab parameters. I mean, as Gaurav said, age of the patients, then other comorbidities do help in prognostication of the disease, but other lab parameters which may help us in a subtle way to decide whether how would this patient do in near or long term future are very important in serum sodium levels at the level of at the time of presentation. Second thing is ejection fraction. That's like that we all know. And the most important thing, which is generally not discussed, is the response of the patient to therapy. If at all patient responds to therapy in first few days or first few hours, and then there are no repeat hospitalization, in long term the patient, he or she will do well. But if there are recurrent heart failure in spite of having optimal medical therapy, then probably long term prognosis is not good. That's what I wanted to do. Moving to next slide. So having said, I just told, we all know that MRAs are one of the most important pillar among medical therapy in management of patients with heart failure. But still, all of us use ACE inhibitors, ERNIs, or beta blockers, or nowadays the SGLT2 without any great inhibition. But MRAs, I am very sure we are not as comfortable as using ACE inhibitors or ERNIs in patients with heart failure. So there are few deterrents of not using MRAs in patients with clinical practice. So what do you think, Dr. Paresh sir? So can you throw some light on some of the major deterrents of not using mineral corticoid receptor antagonist in clinical practice in patients with heart failure? Sir, there? Dr. Paresh sir? Ravi sir आहेत का?
सर आहेत सर.
At all, he's going to take this question, then probably. Otherwise,
Okay. Parvez sir.
Hello.
hello. Sir, good evening, sir.
Good evening.
Sir, we were just discussing
Yes,
the
yes.
role of MRAs, and then we thought it's not being used as much as it should be. So,
Yes.
in our clinical practice, what do you think? What are the major deterrents of to us, which we think of not using MRAs as much as they should be?
Sir, can you hear me, sir? Good evening.
Yes, yes, sir. We are.
See, there are two important mineral receptor antagonists available, and both are extremely useful in the all types of heart failure, as you said, the spironolactone and eplerenone.
Right.
Yes. So they can be used in from New York Heart Association class 2 to 4 type of heart failure, stages of heart failure, and they should be combined with ACE inhibitors, ARBs, but we should be careful, because when we combine with ACE inhibitor ERNI, the chances of hyperkalemia will be more. So we should be more careful when we are combining. Secondly, from the various trials, it is known that the MRA in the lower dose they are safer. Like spironolactone, 25 milligram is much safer than 100 milligram. So low dose is safer than the higher dose. So if you are at all using a very high dose, so we should be careful, and we should regularly check the potassium levels. And other side effects like gynecomastia is very important, and it is more common with spironolactone than eplerenone because the spironolactone is non-selective. It acts on the estrogen and other receptors, which can lead to 10% cases painful gynecomastia. This is not seen with the eplerenone.
Right. So
Another important point is that both can cause in 10% cases serious hyperkalemia. So there are certain points I will discuss with you. We should administer not more than 50 milligram per day of the according to guidelines, or not more than 50 milligram of the mineralocorticoids. And if the GFR is less than 30 ml, and if the creatinine is more than 2.5 in men and 2 in women, we should be very careful. And in case of elderly patients, they are more prone, above 60, they are more prone for hyperkalemia. And we should be careful in the diabetics. The diabetes, they carry extra high risk. And we should not combine with the NSAIDs. NSAIDs will increase the chances of serious hyperkalemia. And we should not combine with other potassium sparing diuretics.
Right. So, sir, very well said, sir. That's what the whole the major deterrents of us not using MRAs in clinical practice, I believe, are patients with fear of us of patient developing serious hyperkalemia, and usage of MRAs in patient with underlying CKD. So these are the two major deterrents which I think which sir have told us that prohibits us of routine use of MRAs in patients with heart failure. So we have few things to overcome that, and then probably according to expert committee of ACC 2017, and which was updated in 2021, we should exercise caution when using MRAs in patients with heart failure. If at all underlying patients' potassium levels are more than 5 millimole per liter, and patient have severe renal impairment, as just Parvez sir has told, that if at all creatinine is more than 2.5 and more than 2 in male and female respectively, then probably we should exercise extra caution in usage of MRAs. So thank you, sir. Thank you for your inputs in re-emphasizing what are the deterrents and what caution we should take in usage of MRAs in patients with heart failure. So having said that, then managing potassium levels, managing creatinine levels and EGFR becomes mandatory in patients in managing patients with heart failure, especially when they are prescribed MRAs. So how often these parameters are done when patients with heart failure are being prescribed MRAs, and after initiating MRAs, how frequently they should be monitored? So this question I would put forth to Dr. Poekar sir, if at all is hearing us. I think I request him to take this question.
Yes, thanks and good evening and namaskar to all. While using MRs, most of us fear about the high potassium, and probably to initiate these drugs at the time baseline, we usually do creatinine and potassium levels. And after starting these drugs, if these at the time baseline, if the reports are normal, we repeat this test after 1 week of starting this. And if we want to increase the dose or change the dose of spironolactone or iprenlinone, then we again repeat it after 1 week. If we stay on the same doses of the potassium, and if we stay on the same doses of the drugs, then we repeat it after monthly for first 3 months. And then if the reports still remain normal, then every 3 monthly for a year, and then after a year we repeat it after 6 months. So usually if the reports gets worse, or if there is any change in the drugs, then we repeat it more frequently. Otherwise, this is the routine which we follow when we are starting these drugs.
Yes, right. So this is how what sir has said regarding monitoring of potassium levels and KFTs when patients are being prescribed MRAs. So as far as European Society Cardiology 2021 heart failure guidelines, MRAs are classified as class 1 drugs in patients with heart failure with reduced ejection fraction, which helps us to reduce the risk of heart failure, hospitalization, and death. And with patients with heart failure with mildly deranged ejection fractions, MRAs are known to reduce heart failure, hospitalization, and death, but its class of indication is class 2B. So, having said that, what percentage of patients you use MRAs for heart failure management, and when do you consider, what subset of populations of patients with heart failure will you consider usage of MRAs along with ACE inhibitors or IRBs and beta blockers? So I request Vishal, Dr. Vishal Dhakre to take this question.
Good evening, all.
Yeah,
good evening, all. Yes. In our routine practice, around 30 to 40% of patients we go with using the MRAs. In especially cases to reduce the post-discharge recurrent hospitalization or in-hospital failure, especially in those cases of thrombolysis cases or late presentation. Initially, after adding AC inhibitors, the aldosterone level reduces to slightly, but after some time, it reaches to the normal level. So it is called as aldosterone escape. After adding AC inhibitors, we may add ARBs also along with AC inhibitors. But over a period of time, this escape phenomenon give rise to positive feedback mechanism, and which increases the AC angiotensin 2 level. And this is the cause for the blunting effect of the AC inhibitors or ARBs over time. So it is the MRA which causes positive benefits in such cases. So ideally at the time of discharge, in those cases, especially patients with reduced ejection fraction or moderately reduced ejection fraction, we should consider MRAs as the primary line for reducing heart failure.
Very well said, Vishal. Just as Dr. Vishal sir has told, he has re-emphasized that we all, in spite of knowing the benefits of MRAs in patients with heart failure, it is being used in only 30 to 40% of the patients. So that's what we are all here for, just to update ourselves and just to re-emphasize the usage of MRAs in patients with heart failure patients. And as he rightly said, initiating it has shown to decrease rehospitalization and in hospital heart failure events whenever they are combined with ACE inhibitors or ARBs and beta blocker. That's right. Thank you, Vishal. So till now we have been discussing hyperkalemia, and we are all bothered of our patients developing hyperkalemia. It's a serious hyperkalemia. So my question to Dr. Pagare sir, what percentage of heart failure patients on MRS develop hyperkalemia in your clinical practice, and how do you manage the patients developing hyperkalemia?
Good evening, everybody. Hyperkalemia is one of the major side effects for the this mineralocorticoid. So basically, it depends upon different studies. According to the RAIL study, the hyperkalemia percentage, if a patient had a normal lactone level, means normal spironolactone, if you use in 25 milligram of spironolactone and 50 milligram of eplerenone, the 13% chances of developing hyperkalemia is there. If you're using more, 50 milligram and 75 milligram, the chances of hyperkalemia is 20 and 24%. And the 1 year chances of developing hyperkalemia is about 18 to 20%. According to the Japanese study, it depends upon in which condition we are using. So in case of CKD, it is 22%. In heart failure, it is 13%. Diabetes, it is 10 to 11%. Hypertension, it is again 10%. So percentage of hyperkalemia, it is dependent upon the patient we are using. So we should be very cautious while using in patient of CKD or patient with diabetes or patient with severe heart failure patients. And it also depends upon the age or creatinine clearance is very important. Again, along with the AC inhibitor, ARB, there are chances of more of hyperkalemia. So while selecting the patients, we should have lower dose, means 25 milligram of spironolactone, and the 50 milligram of eplerenone is the dose which causes less hyperkalemia. Again, so if patient develop the hyperkalemia, we should, as Poekar said, we should titrate it, or we should, after 1 to 2 weeks or within 1 month, we have to do the potassium levels. If they are high, then we have to titrate those or we have to withdraw the dose. Okay, and again, there are other factors also. We should advise the patient to potassium sparing diet. We should advise to them. And if patient develop hyperkalemia, then we should give the potassium binding sachets. We have to give. Again, if we are giving any drugs, means diuretic, loop diuretic, we are giving, we have to withdraw it, these drugs. So all these measures can be tackled to deal with the hyperkalemia.
Very well said, sir. So what sir told, what we gather from what sir has told is that there are the incidence of hyperkalemia differs from patient to patient, and there is certain high risk population who are known to develop hyperkalemia. This population includes patients with diabetes mellitus, patients with underlying CKD, patients with concurrent use of ACE inhibitors or ARBs, patients with concurrent use of NSAIDs. These are the patients who are more likely to develop hyperkalemia, right, sir?
Right.
And regarding management, the best thing to manage hyperkalemia is to monitor potassium levels. The target level of potassium should be somewhere between 4 and 5.5. If at all potassium levels remain below 4, in spite of we giving MRAs, so probably we can escalate, go on or increase the dose of MRAs. But if at all potassium level and if they remain between 4 and 5.5, then that's okay. But if at all potassium levels go above 5.5 and below 6, then probably it is better that we decrease the dose of eplerenone or spironolactone to half, because as sir has said, hyperkalemia is dose dependent. Hyperkalemia. So if at all patients develop hyperkalemia, but not to great level, I mean not to very serious levels, we can always use MRAs, but at decreased dose. If at all patient develops serious hyperkalemia, that is potassium of more than 6, then probably we need to stop MRAs immediately. We then monitor potassium at more frequently, and at some time we need to prescribe patients with potassium binders as well. So this is the slide which sir has told that MRA related hyperkalemia in one of the studies has shown to be seen in almost 9.3% of the patients, but we need to assure that the hyperkalemia which the patient has developed is truly due to MRA related. In this particular study, it was shown that almost 50% of the patients did not have hyperkalemia which was related to MRAs. Only 54% of patients had hyperkalemia truly related to MRA. So this is one point again we need to consider, because there are other factors also because of which patient can develop hyperkalemia. That is, patient is on ACE inhibitors or ARBs, or patient have renal tubal type 4 RTA in patients with diabetic and CKD. So this is the slide, if at all we all can appreciate, which is proposed for development for dose adjustment in patients with hyperkalemia after using spironolactone and eplerenone. As we can see that if the potassium levels go more than 5.5 but less than 6, we have to decrease the dose of spironolactone as well as eplerenone. But if at all if they go above level of 6, then probably we need to stop MRAs immediately. So thank you, Bagare sir, for your output.
Thank you.
Input, sorry. So having said that, MRAs being now we all know that MRAs are the essential part, one of the 4 major pillars in patients with heart failure. The most of the patients of MI have LV dysfunction, and we all know that MRAs have a role in LV dysfunction as well. So what is the status of MRAs in post-MI patients? Whether it be used in all post-MI patients, or they be used with decreased ejection fraction only. So I request Dr. Ghanshyam Chandak to take this question. Dr. Chandak is here.
Dr. Chandak, sir.
आहेत का सर?
तो आहेत.
Should we wait for his answer?
Yes, he's resigning, having some emergency.
Okay, so should we wait for him or should we proceed?
We will proceed, sir. Meanwhile, they will come and you can ask.
So basically this slideshow I just wanted to discuss with you, and but then already this topic has been discussed with by Dr. Vishal Dhakre sir regarding aldosterone escape. This is very important slide, very important aspect of using what is the role of early initiation of MRAs in patients with heart failure. As Dr. Vishal has said, I am just repeating it. When you use ACE inhibitors or ARBs early in the heart failure management, there is acute fall in aldosterone levels. But after some time, aldosterone levels returns to baseline in almost all patients, known as aldosterone escape phenomenon. This phenomenon is seen even if ACE inhibitors are combined in ARBs. I mean, strong inhibition of RAS system, still there is, due to positive feedback loop, the aldosterone level increases. And this leads to blunted effect of ACE inhibitors, known as ACE resistance. That's why to decrease this aldosterone escape phenomenon, we should be using MRAs along with ACE inhibitors or ARBs as early as possible in patients with heart failure. This is the slide which shows what is the timing of eplerenone in initiation and outcomes in patients with heart failure after acute myocardial infarction complicated by left ventricular systolic dysfunction, as emphasized by EFESIS trial. And this trial showed compared the mortality benefits in patients with heart failure post MI when we had used eplerenone early, that is within 7 days of MI and after 7 days of index event. And this slide shows that when compared to use of early eplerenone vis-a-vis use of eplerenone after 7 days of discharge, there was 31% reduction in all-cause mortality in patients with heart failure post-MI by eplerenone when compared with placebo when initiated before 7 days and after 7 days. There was definite 34% risk reduction in patients with heart failure in decreasing sudden cardiac death in patients of heart failure post-MI when eplerenone was used within 7 days versus use of eplerenone after 7 days. So this slide emphasizes the usage of eplerenone early in patients with patients with AMI with heart failure. So having said that, MRAs are definitely useful, and they are here to help us decrease mortality in patients with heart failure. But still, there might be some difference between eplerenone and spironolactone. So, when would you prefer, and why would you prefer eplerenone or spironolactone? I request Dr. Mahesh Bansode sir to take this question. Dr. Mahesh.
Yes, sir.
Good evening.
Good evening. I'm visible.
Yeah, you are visible and audible as well.
Yes, sir. Good evening to all my colleagues and my teachers. As far as eplerenone and spironolactone concerned, in terms of heart failure, sir, there are more studies which compares that eplerenone is having less hyperkalemia in the same dependent dose. If you use eplerenone 25 or spironolactone 25, the chances of getting hyperkalemia are less with eplerenone as compared to spironolactone. So as we said, the patient who are prone to hyperkalemia, mostly heart failure patient with diabetic nephropathy or who is having reduced EFR, in that case you have to preferably use eplerenone. That is much and one more thing, the eplerenone is very selective only on mineralocorticoid receptors, while spironolactone is having mineralocorticoid plus androgenic receptor activity. So it is more prone to give that painful gynecomastia and reduce impotence in male patients. So it is also given a choice to patient because the spironolactone is having more symptomatic relief as compared to eplerenone, as they said. And one more major benefit that if we are using eplerenone versus spironolactone in patient with resistant hypertension, not with heart failure patient, but the patient who are having resistant hypertension, and we are having primary hyperaldosteronism. In this case, the angiotensin 2 is not elevated. In that case, the more studies said that you have to use spironolactone as compared to eplerenone.
Yeah.
Because the efficacy of decreasing hypertension is more with spironolactone.
Yeah.
So these we have to consider.
Yeah. Perfect. Very well said, Mahesh. Very well said. Just a couple of things which I wanted to add. There is one meta-analysis study which was published in patients from University Heart Journal in 2020 recently, where they compared use of eplerenone versus spironolactone, and they compared whether what was the recovery, what was the improvement in systolic function when eplerenone was compared with spironolactone in patients with heart failure. It was seen that both improved LV systolic dimensions, both improved ejection fraction to some extent, but the degree of improvement in LV systolic diameter and LV and systolic volume and degree of improvement in ejection fraction was slightly better in patients with eplerenone vis-a-vis spironolactone. Not much difference, but yeah, subtle difference are there, wherein they found that the cardiac effects of eplerenone are slightly better than spironolactone. But we have our own hitch in using eplerenone. The major hitch I would say in clinical practice is its availability. Do you agree? Regarding availability of spironolactone is much easier than eplerenone.
Yes, sir. Yes,
that is till now we have discussed usage of MRAs in heart failure patients, but there are subtle indications, other indications as well, wherein MRAs are very helpful. Apart from its uses in heart failure patients, just now Dr. Mahesh told they can be used in resistant hypertension. Though there are certain other clinical indications of usage of MRAs in our clinical practice, wherein we prescribe them in patients who don't have heart failure as well. So I request Abedi sir to take the question, please. रवि अभिजी सर आहेत का?
Sir, I think Abhijit sir has left.
Okay. He had some emergency, he told.
Yeah.
So I'll just take this question himself. Basically, just as Dr. Mahesh has said, it's basically their usage in certain patients with resistant hypertension, patients with suspected primary hyperaldosteronism, patients with cirrhosis of liver, and it can be used in patients who have unexplained hypokalemia as well. So these are few indications of usage of MRAs in clinical practice other than usage in heart failure.
Mukund, can I add one thing?
Yeah, please, sir.
There is a condition called as a Bartter syndrome, which is actually salt-losing tubulopathy.
Yeah.
We had 2 patients of that, and actually low dose of spironolactone and NSAID was used, and patients did well for a few years.
Yes.
So this was one indication which I felt we should have.
Perfect. So this question is for all panel members. I request each and everybody to have their inputs. So what are the scientific benefit initiatives you would suggest to our CIPLA company for creating increasing awareness for usage of MRAs in various clinical conditions among its GPs? Because I know that we have been very aggressive in treating patients with heart failure with ACE inhibitors, ARBs, beta blockers, and nowadays dapagliflozin and empagliflozin has been rampantly used in patients with heart failure with reduced ejection fraction as well as with patients with the preserved ejection fraction. But still, MRA uses has not been picked up as much as they should. So we all should take efforts to re-emphasize its role, because it's definitely one of the pillars, one of the 4 major pillars which have shown to improve mortality or give us mortality benefit in patients with heart failure.
Sir, I have one question, please.
Yes, please do.
Sir, most of the patients who are having ejection fraction less than 15 or 20, the major thing is they are having hypotension. They are only systolic BP in 80 or 90. Yeah. So the titration of we can't able to titrate above beta blocker also. Yeah. What should we do in that case?
That's what that is. I mean, this is the real life scenario question wherein patients with very poor ejection fractions have low BP. But having said that, we should all be aware that their blood pressure setting is has gone down. So they tolerate systolic BP of 80-90 as much as they should be. So we should not be bothered by BP readings itself. We should go by their symptoms. We should go there by perfusion levels, like their urine output, their skin turgor and all. And then probably in such type of patients, by default, they have very low ejection fractions. If at all they are not in clinically overt heart failure, we would start them on very low dose of ACE inhibitors on ARNIs, and then go titrate up one drug at a time.
Okay, sir. Thank you.
But
thank you, sir.
Usage of all drugs at a time, like MRAs, ACE inhibitors, and beta blockers would be detrimental. They would, I mean, probably they won't take it as much as they should. Other patients would take. So I think that's it from my side. If anybody wants to discuss some other point regarding MRAs and heart failure, we would. I'll be more than happy.
Yeah, na.
So it was a good session. Probably we had a very fruitful discussion amongst ourselves. It was very pleasure seeing all my colleagues after some long time. I enjoyed having a word with them regarding heart failure and MRAs. I think we should call it a day, and then Ravi,
Yeah, yes, sir.
anything from your side?
Yeah, thank you very much, sir. It's an pleasure to have you on this platform, sir. And all the delegates, I want to say thank you all of you being here today and taking the time of patiently listen and participation. And it's been a pleasure being with you all today. Thank you for all your patience. I wish you all a very good night, sir. And thank you for your participation. And we are planning another session with you all again and again. And thank you, sir. Thank you very much.
Yeah, thank you. Thank you. Good night. Good night, you.
Thank you, sir.
Thank you, Mukund sir.
Yeah, bye-bye. Good night.